This section labeled lymphoma will also include myeloma, monoclonal gammopathy of unknown significance, and Waldenstrom's macroglobulinemia. Non-Hodgkin's lymphoma is a proliferation of lymphocytes in the nodes in the spleen. Non-Hodgkin's lymphoma is most often widespread at presentation. In other words, 80 to 90% present in stage 3 or 4. Very rarely do you have a localized non-Hodgkin's. Non-Hodgkin's and CLL are virtually identical. Non-Hodgkin's is a solid CLL, and CLL is like a liquidy non-Hodgkin's. Non-Hodgkin's is solid. You need to do an excisional biopsy, and CLL is liquid or circulating. Both of them are characterized by lymphocytes that individually look normal. You can only tell that they're a disease by looking at the group of them and seeing how they function. Lymphadenopathy is worse for you prognostically if it's not painful. Painless lymphadenopathy is cancerous. Cancers are not tender. Infections are tender. Infections are tender, warm, and red. Lymphoma is not. Now, these lymph nodes can also involve the pelvic, retroperitoneal, and mesenteric structures. And it's not good to have pain, but it's good in terms of not having cancer. Cancerous nodes are not warm, not red, not tender. Now, sometimes people with lymphoma can have what we call B symptoms. And as a group, this is a sign of spread. We believe that B symptoms means that even though you cannot see it, it means that that lymphomatous cell tissue is spread around the body, causing fever and weight loss and really, truly drenching night sweats. People feel like they have to change the sheets during the night, twice even, like somebody came and threw a bucket of water on the bed. Now, non-Hodgkin's is advanced in 80 to 90%, and it's infection, not non-Hodgkin's, that gives nodes that are warm, red, and tender. And when we say weight loss, we mean more than 10% of body weight. 5% weight loss often doesn't count. 5%, 6% doesn't count. 5 pounds, 6 pounds don't count. It has to be 10% to count. For lymphoma, both Hodgkin's and non-Hodgkin's, the best initial test for both of them is excisional biopsy. And this is because you've got to see the architecture of the whole node. You can't just do a needle. A needle is good for infections. A needle is good for tuberculosis or for fungus, for TB or for fungus. Needle at TB or fungus. But you've got an excisional lymph node biopsy. It means it takes the whole node and see what the architecture is like. The CBC is normal in most cases. That's the number one clue to why it's not CLL. CLL has a very high white count. It's all lymphocytes. But lymphoma is localized lymph nodes. And this is very important because remember that CLL can give big lymph nodes as well. How would you know it's not CLL? The answer is CLL is always a high white count, that's lymphocytes, and lymphoma rarely has a white count, that's all lymphocytes. Rarely it's localized to the nodes in lymphoma. Both of them can have a high LDH, and both of them have an LDH, and in lymphoma it really does correlate with the severity or extent of disease. The higher the LDH, the worse the severity. Now, staging is important because localized disease is treated often with more radiation than chemotherapy. So localized disease can be radiated. You can't radiate extensive disease. Also, localized disease does just not need as much chemotherapy and hence doesn't need all the adverse effects of that chemotherapy. So staging determines the intensity of therapy. So the staging procedures are a CT scan of the chest, the abdomen, and the pelvis. Let's see how far it is. Is it on both sides? Both sides of the diaphragm. Both sides of the diaphragm, stage 3. Much worse. And a bone marrow biopsy. You do not have to do laparotomy, which is to cut the abdomen over and take a look inside. You do not have to do lymphangiography. Lymphangiography is never correct under any circumstances for any disease anymore. Lymphangiography, when you see it, is a dead test. The staging for Hodgkin's and non-Hodgkin's is the same. Stage 1 is one lymph node group. Now, one lymph node group doesn't mean one lymph node. It means that it's just the cervical, or just the axillary, or just the supraclavicular. Stage 2 means 2 or more lymph node groups, but they're on the same side of the diaphragm. Now, this is critically important because stage 3, both sides of the diaphragm, has a much worse prognosis. First, there's a much greater burden of disease. Second, you can't radiate both sides of the diaphragm. You'd have to give combination chemotherapy and have to give it at higher intensity, higher dose, and longer. And that means you're subject the person to more vincristine-induced neuropathy, more vinblastine-induced neuropathy, more bleomycin-induced lung fibrosis if it's Hodgkin's disease. So the wider spread the disease, the more likely you are to have the complications of chemotherapy. Stage 4 is generalized widespread disease. Now, the most common wrong answer is a needle aspiration of the node. Aspiration is simply not enough. You can't needle cancers because the individual lymphocytes look normal. Local disease is radiated. Local means stage 1A and 2A disease. Any B symptoms or anybody with stage 3 and 4 gets treated with combination chemotherapy, and if their CD20 is positive, with rituximab as well. Now, C means cyclophosphamide, and H is hydroxyadriamycin, hydroxydaunorubicin. O is oncovin, but that really means vincristine, and P is prednisone. Now, mucosal associated lymphoid tissue is a lymphoma of the stomach in association with Helicobacter pylori. It's much more minor and it's treated with proton pump inhibitors, clarithromycin, and amoxicillin. So it's PPIs, clarithra, and amoxicillin. So we chop the non-Hodgkins and ABVD and MOP the Hodgkins. It's very rare that we treat a non-Hodgkin's with radiation because most of the time they're too widespread. Remember, it's mostly diffuse at presentation in a non-Hodgkin's. In Hodgkin's disease, the presentation, diagnostic test, B symptoms, and staging are the same, except for the fact that it's far more local. It's stage 1 and 2 in most cases. The big issue is the histology. Hodgkin's disease has a Reed-Sternberg cell on pathology. Now, lymphocyte predominant is the best prognosis. Lymphocyte depleted is the worst prognosis. So it means that the major difference between these is the histology. Now, you do not have to learn the difference between 14 separate types of non-Hodgkin's lymphoma. That's not the point here. The point here is that don't needle lymphomas, do an excisional biopsy, that you have to stage them to know if it's local disease because we want to try and use more radiation and less chemotherapy because there's less long-term adverse effects. And the major difference is not the staging is the same, not the B symptoms. Fever, weight loss, and night sweats are the same for both. The difference is the histology. So the differences between Hodgkin's and non-Hodgkin's lymphoma is that Hodgkin's is stage 1 and 2 in 80 to 90%, whereas Hodgkin's is stage 3 and 4. This basically says, if you look at the left side of your screen, radiate me. If you look at the right side of your screen, chemo me. Hodgkin's disease starts at the neck, at the cervical area, and spreads outward from there. Non-Hodgkin's is disseminated at presentation. Hodgkin's has a different pathology, notably the Reed-Sternberg cell. Non-Hodgkin's has no Reed-Sternberg cell and a much more complicated pathologic system that you don't have to learn here. The pathologic classification for Hodgkin's, you have to know as far as lymphocyte predominant has the best prognosis, lymphocyte depleted is the worst prognosis, and in non-Hodgkin's, the pathologic classification that Burkitt's and immunoblastic have the worst prognosis. That's called high-grade lymphomas. Now, I got to tell you something about non-Hodgkin's. High-grade lymphomas may be the most aggressive. High-grade lymphomas may grow the fastest. High-grade lymphomas may be the most likely to kill you. But because they divide very quickly, because they're aggressive and they change and divide and grow, does chemotherapy work on you when the cell is at rest, or does chemotherapy work when the cell is dividing? Chemotherapy works when the cell is dividing. So if you have a rapidly dividing cell, you have a greater chance to cure. So the good news is you have a greater chance of curing it outright with high-grade lymphoma, Burkitt's and immunoblastic. The bad news is if you can't cure it, you have a greater chance of dying. Stage 1A and 2A disease is treated by a combination of local radiation and chemotherapy. There's a change in the sense that virtually no one is treated with radiation alone anymore. It's a combination of radiation and chemotherapy. Although in stage 1A and 2A disease, at least you can use much less chemotherapy and therefore avoid a lot of the toxicity. Stage 3 and 4 disease is treated essentially exclusively with chemotherapy, or anyone with B symptoms gets ABVD. Adriamycin, bleomycin, vinblastine, dacarbazine. And remember, relapses after radiation are treated with chemotherapy, but relapses after chemo have to be treated with super extra high dose chemo with a bone marrow transplantation. Bone marrow transplantation actually allows you to really bump up the volume on that chemotherapy, bump up the dosing to try and cure someone's disease that was initially refractory to therapy. The complications of radiation and chemotherapy are that radiation increases the risk of solid tumors such as breast cancer and lung cancer, sometimes thyroid cancer, depending on where the radiation is aimed. And you have to screen for breast cancer earlier after the treatment. Now, radiation also increases the risk of premature coronary disease. When you zap that chest with radiation, you can age those coronaries, cooks them, fries them. And the risk of acute leukemia, MDS means myelodysplastic syndrome, and non-Hodgkin's lymphoma from chemotherapy is about 1% a year. You could throw in aplastic anemia there too. And basically, chemotherapy gives a risk of secondary malignancies. But it's not enormous, except if you're thinking that people can get radiated and chemotherapy over a period that lasts for a few weeks and months, and then they might live after the chemotherapy for 30 years. So 1% a year becomes quite a lot when you consider that you get radiated and chemoed at the age of 30, and then you might get your lung or breast cancer when you're 60, or your leukemia from your chemotherapy at the age of 60 or 70. Then it's quite a lot. So which of the following is the most useful to determine the dosing of chemotherapy in Hodgkin's disease? In other words, you've got to really bump up that volume of chemo to cure it. If you give too much, it's toxic. If you give too little, you don't cure them. So what do you use to determine the dosing of the chemotherapy? The answer is the MUGA, or nuclear ventriculogram. This is probably the single most clear use of the MUGA, or nuclear ventriculogram. How do I precisely dose the chemotherapy to make sure I've eradicated people's lymphoma but not killed them from the toxicity? See, the echocardiogram is just not accurate enough, and bone marrow biopsy is not accurate at all. Gender is essentially irrelevant, and the hematocrit and symptoms aren't good enough to tell me, hey, the nuclear ventriculogram is going to allow very precise dosimetry of adriamycin, enough to cure the lymphoma, but not so much to cause cardiotoxicity. The two most frequently tested facts for oncology are what are the screening tests and what are the toxicities of chemotherapy. It is absolutely indispensable that you understand doxorubicin is cardiotoxic, vincristine and blastin give a peripheral neuropathy. It is permanent, vincristine and blastin, peripheral neuropathy. Bleomycin with an irreversible lung fibrosis. Cyclophosphamide with a hemorrhagic cystitis that can be prevented by MESNA, M-E-S-N-A. Cisplatin is renal and oto and renal toxicity. Indispensable for you to know. Myeloma is plasma cell cancer. It's the unregulated production of useless plasma cells that make useless immunoglobulin. And it is usually IgG or IgA, but infections come into the body, and instead of making useful immunoglobulins that fight the infection, it makes an unlimited amount of useless immunoglobulin. That is a monoclonal spike. Monoclonal spike, sometimes called an M spike. And guess what the most common wrong answer is for students? Confusing the word M spike with IgM. That's a natural mistake, but IgM does not mean an M spike. Myeloma makes IgG and IgA. Waldenstrom's macroglobulinemia makes a monoclonal spike with IgM. This is like having, myeloma is like having a TV that plays one channel very loud and unclearly. Immunoglobulins don't fight infection. They're abnormal. They're crappy. They just clog up the kidneys. And the IgM is just not myeloma. The most common presentation of myeloma is bone pain from pathologic fracture. The plasma cells make a kind of an osteoclast activating factor. The pathologic fracture means it breaks under normal use. If you get hit by a car or fall off a roof, that's not a pathologic fracture. It's unfortunate, but you fell down, you get hit by a car. Pathologic fracture means you're working normally, you're living normally, and the thing still broke. Ouch. Osteoclast activating factor is made by the plasma cells. Basically, the plasma cells make a factor that melts bones and causes lytic lesions. And they are purely lytic lesions, no blastic activity. That's why they don't light up in a bone scan. Ding, 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 ding. Important question, don't light up in a bone scan. And they do create hypercalcemia as they melt your bones and melt the calcium out of your bones. Infection is common because the abnormal plasma cells don't make immunoglobulins that are effective against infection. So the two most common causes of death in myeloma are, 1, infection, number 2, renal failure. Hyperuricemia happens because there's an increased turnover of nuclear material in plasma cells. Why doesn't this happen in hemolysis? Because red cells don't have nuclei. Red cells don't have nuclei, so you don't get hyperuricemia. You just get the hemoglobin released. So the uric acid comes out of purines and pyrimidines, which are only in the nucleus, and that's why they're quite politely called nucleic acids, because they're in the nucleus. Oh, yeah. And you can prevent the damage from pegloticase and rasburicase. Pegloticase and rasburicase, what they do is they melt uric acid. They're uric ace. They melt it away into a puff of smoke called allantoin. And that's one of the treatments you give prior to chemotherapy. It basically helps, in addition to allopurinol, to prevent tumor lysis syndrome. You get anemia because these big fat extra abnormal plasma cells move into your marrow by the billion and crowd out the nice normal cells. And renal failure happens because immunoglobulins clog up your glomeruli, Bench-Jones proteins damage your kidney tubule, and the kidney doesn't like the high calcium either. Hypercalcemia by itself is toxic to kidney tubules. So between the hyperuricemia, the Bench-Jones proteins, and the kidney tubules, your kidneys have a lot of damage, and that's why these are the two most common causes of death in myeloma. The best initial test is an X-ray of the affected bone. You're going to see lytic lesions. A serum protein electrophoresis is not the single most accurate test because monoclonal gammopathy of unknown significance is far more common than myeloma. Now, serum protein electrophoresis, the SPEP, shows an IgG in most people, an IgA in the others, and some people can have two types, both an IgG and an IgA. Remember, one type of immunoglobulin, monoclonal REM spike, but it doesn't mean it's an IgM. 15% have light chains or Bench-Jones proteins only. But this also is why Bench-Jones proteinuria is not the most accurate test for myeloma. Myeloma is first with bone pain. Therefore, X-ray that bone for lytic lesions. The bone scan won't show anything. SPEP helps to confirm it. Hypercalcemia is non-specific, and so is hyperuricemia. The additional abnormalities of myeloma is hypercalcemia. The bone's destroyed. Of course there's hypercalcemia. Bench-Jones proteins are immunoglobulin parts that appear in the urine. But remember, you can't see Bench-Jones proteins on a urinalysis. The urinalysis only detects albumin as a protein. As a protein, it does not pick up the Bench-Jones proteins. You got to do a urine immunoelectrophoresis. Beta-2 microglobulin is a one-disease test. It looks for the severity of disease and corresponds to the prognosis in people with myeloma. We don't use it for anything else except myeloma. Now, rouleau is a fancy French way of saying rolls, red cells in rolls. And they are because the red cells literally stick together because they get covered with sticky plasma proteins, which make them form into rolls, rouleau. Bench-Jones proteins create an elevated BUN and creatinine, as well as hypercalcemia, hyperuricemia. But if you had to choose the single most accurate test, the one test that is the most specific, it is plasma cells on bone marrow biopsy. 10% plasma cells in combination with lytic lesions and an SPEP is enough. 30% plasma cells as a single finding with nothing else is myeloma. But in combination with SPEP, hypercalcemia, 10% plasma cells. Nothing else causes that level of plasma cells in a bone marrow. There is an elevated total protein with a normal albumin, and that's why you should get the serum protein electrophoresis, the SPEP, to dissect it as a single test, plasma cells. Urinalysis doesn't show Bench-Jones protein, and bone scan won't show lytic lesions. Those are the questions. Learn them. Well, everything is more exciting in French, I suppose. Do you have rolls? No, I have rouleau. That's the IgG paraprotein. Paraprotein means an abnormal extra protein. It means non-albumin. That's what it basically means. Non-albumin extra protein. They make the red cells sticky to each other in a stack. Now, rouleau don't have an effect. It's not like spherocytes, which actually damage your spleen and make the spleen big. They don't clog things up like Waldenstrom's clog up your brain and your eye and cause a stroke. They don't cause priapism like in sickle cell. They're just a laboratory artifact, really. And as such, they're just a tested question. Which of the following is associated with rouleau? Myeloma. Who lower found is what's most likely to be the diagnosis? Myeloma. That's the only question. Just remember, oh, there it is. M spike doesn't mean IgM. Myeloma has a decreased anion gap. This is a tough to understand point. Since IgG is cationic, positive, it actually lifts up the chloride and bicarb, which are anions. Now, there's a lot of things that cause an increased anion gap, but few that cause a decreased anion gap. The anion gap is 6 to 12 points of difference between sodium, which is a cation, and the anions, which is chloride and bicarb. If you raise the chloride of the bicarb, the gap, the difference between the sodium and the chloride of bicarb goes down. So since the IgG is cationic, there is an increased number of chloride and bicarb atoms that match it, and hence the gap goes down. And therefore, you could also memorize which of the following is the only thing that has a decreased anion gap: myeloma. IgG cationic. Well, here we have a 69-year-old woman with back pain, and it worsens, it pops. When she coughs, it feels worse, tenderness over the ribs. She's got lytic lesions on x-ray. Calcium is 2 points above normal. She's anemic. She's got renal failure. She's got trace protein, but 5 grams of protein on 24-hour urine. What is that? Well, that's Bench-Jones protein. What are you going to find on that bone scan? The answer is nothing. It's nothing because lytic lesions don't light up a bone scan. Lytic lesions don't light up a bone scan. You don't have any increase in uptake and doesn't change anything. It's just invisible. Nuclear bone scan only shows increased uptake with osteoblastic activity, which is absent in myeloma. You see, other cancers, when they form metastasis, have lytic and blastic and lytic and blastic. Osteomyelitis had lytic and blastic and lytic and blastic. There's destruction, formation, destruction, formation. But myeloma is one of the only things that's purely lytic. Why the difference between the protein on urinalysis, 24-hour urine? It is, read, Bench-Jones protein isn't picked up by a dipstick. Bench-Jones protein needs a urine electrophoresis. Urine dipstick only detects albumin. What is the single most accurate test for myeloma? The single test that's the most accurate is the bone marrow biopsy, because nothing besides myeloma has 10% plasma cells on bone marrow biopsy. Skull x-ray shows lytic lesions, but it's not as specific. We rarely do skeletal survey anymore, and the others are simply not as specific. The best initial therapy for myeloma. Now, this is a moving target, and so I want to assure you that the wrong answers will be really wrong. The wrong answers will be like cisplatin, something really horrible. See, it's one or a combination of these drugs. Lenalidomide with steroids, bortezomib and lenalidomide, melphalan and steroids, melphalan, lenalidomide and steroids. A combination of these things. Now, not necessarily all of them together. Can be 1 or 2 of them, all 4 of them sometimes. The most effective thing under 70, you can do an autologous bone marrow stem cell transplant. Why can you do autologous and stem cells up to 70? Because with stem cells, the bone marrow recovers faster. Stem cells are already a little pre-grown, so instead of waiting 14 days for the bone marrow to come back to life, or 21 days for some people with allogeneics, the cells will come back to life in 7 or 10 days. You see, you can stop bone marrow growth in anybody for a day or two, but after 4 or 5 days of having no bone marrow growth, you start to get infections. After 2 weeks, you start to get fungi, and after 3 or 4 weeks, you get CMV and you die, get aspergillus. So the faster you can get the white cells back, the faster you will recover and the less infections you'll have. The other reason you could do this up to 70 or so is that it's autologous. And autologous means it's you. There's no rejection. There's no rejection, no graft versus host. Now, I know it may seem fuzzy on my therapy question here, the therapy issue, but that's because myeloma therapy is in a state of flux, and it's just not a step 2 question for you. What do you have to know? That some of these drugs are the drugs for myeloma. It's not methotrexate, it's not cisplatin, it's not cyclophosphamide. The monoclonal gammopathy of unknown significance, or MGUS, is super common. It's an IgG or IgA spike on an SPEP. It's extremely common in older persons, 5 and 10% of people above 80. It's a disorder that we didn't even know existed 30 years ago because we weren't doing routine protein testing on everybody. Now you have to see who's got myeloma or not. In other words, are we doing an early detection of myeloma? So you've got to do a bone marrow biopsy to exclude myeloma. See, MGUS has a small number of plasma cells, less than 10%. And there's no therapy for MGUS, but you just got to make sure it is MGUS. In other words, normal calcium, normal renal function, no anemia, no bone lesions, less than 10% plasma cells. It's got to have none of that. Then it's MGUS, then no therapy. And it's not mean that it's no significance. We don't call it monoclonal gammopathy of no significance because it's not no significance to say 1% a year transform the myeloma. I would not consider a 1% a year chance of death to be no significance. It's just unknown who's going to go. So the quantity of immunoglobulin, though, is a really good predictor of who's going to transform. The quantity of the immunoglobulin in the spike is the main correlate of the risk for myeloma. The more monoclonal gammopathy of unknown significance, the more the myeloma. Waldenström's macroglobulinemia is an overproduction of IgM. Malignant B cells lead to the hyperviscosity because IgM is 5 times larger than IgG, so it gets thicker. And that hyperviscosity presents with lethargy, blurred vision, vertigo. And vertigo is also because it sludges your brainstem, man. Engorged vessels that look like sausages in your eyes and the retina. And mucosal bleeding because the overly stuffed blood vessels actually burst like an overstuffed sausage. And some people get Raynaud's phenomena. But basically, it's like myeloma, but with IgMs. Now, the difference is it does not give bone lesions. And the malignant B cells are not the cells that make the osteoclast activating factor. And that's an advantage. It basically just makes extra sticky, abnormal IgMs. And anemia is common because the abnormal cells crowd out the normal marrow. The IgM spike on SPEP makes the hyperviscosity, and the absence of bone lesions is the major distinguishing characteristic for myeloma. Plasmapheresis is the initial therapy to get rid of that viscosity. Now, how come myeloma didn't give hyperviscosity? Well, the answer is simply because IgGs are too small. They're too small to clog you up. But you got to do plasmapheresis to basically send your blood to a dry cleaner. Whip those off and lower the viscosity. It removes the IgM and lowers the viscosity. The long-term treatment, chlorambucil, melphalan, fludarabine, prednisone, basically if it looks like it's a cross between lymphoma and CLL and myeloma, it's because it is. It is. It's abnormal white cells making an abnormal immunoglobulins. You're never going to get asked to choose which single thing is the best therapy because nobody knows. You're going to get asked to recognize the disease, hyperviscosity, and to know that it's plasmapheresis. That's your level of question. Because you got to control the cells to make the abnormal immunoglobulins, Igs, immunoglobulins, and decrease the means of their production.